So finally, NB conducted NEET PG 2025, like after like lots and lots of suspense, story, and everything. Finally, exam done. So now we'll have a pharmacology like a questions and not like in detail session. We'll go through like question and let's see what is the answer and everything such kind of stuff, not in detail. So before starting this pharmacology recall session, no, so overall this NEET PG 2025, it's like many people they're saying it's like easy to moderate paper, not that much stuff, and it's like kind towards inclining towards easy. That's what many people they are saying. And in NEET PG 2025, the OG is obviously it's OBG. Many questions from Ops Gynae and image-based questions, they are not that too high, and apparently they are not that too low even. It's maybe roughly around like 20, 25 image questions were there, as per the information which I got. So with that note, we'll start our pharmacology recall session. And yeah, forgot to add one more point. And this year, NEET PG 2025, I can see lots and lots of PYQs and PYTs. Many, many previous year questions, direct questions, and many previous year topics. And especially with respect to pharmacology, there are many PYTs and of course few PYQs as well. So we'll start one by one now. So myself, Dr. Sudhir Prudvi. Before starting a recall session of pharmacology, so final, there are like roughly 21 questions from pharmacology. And I can tell you from our direct questions from our notebook, there are like around 21, the same. That is 100% strike rate. This 100% strike rate. Each and every question, it came from our workbook. Direct questions from our workbook. Let's see one by one now. So before starting the questions, before starting the class, I always show this graph, like how NEET and INI-CET they differ in giving questions from each topic. In the last May INI exam, I already have shown this graph, so which is dominated by what you call ANS, antimicrobial agents, predominated by those two. Here in NEET, but here in NEET, in class, if you can remember, I told you in NEET, they will not incline towards a specific chapter. They will touch each and every chapter. That is what the statement I told you in NEET. They will touch each and every chapter. At least they will give one question. The same thing happened. Like this is what the graph from the past 6, 7 years. And if you can see this year, 2025, NEET PG 2025, stats from each chapter. General pharmacology, they didn't give in question. From ANS, there are three questions, and respiratory system, there are two, CNS two, diuretics one, CVS two, blood two, GIT one, autokites two, endocrine two, antimicrobial agents four. And they didn't touch these two, general pharmacology and anti-cancer drugs. These are the two topics which they didn't touch it up. They gave almost zero questions. But if you can see INI, general pharmacology almost is the one, at least they will give at least two questions from general pharmacology, and definitely one or two questions from cancer chemotherapy, depending upon the mechanism of action of drugs. So, but here in NEET, except those two, they gave questions from each and every chapter here. Around, as I told you, we have like 21 questions. We will see one by one now, those 21 questions. With that note, we'll start our what you call questionnaires. The first one, in the patients with a pheochromocytoma scheduled for surgical resection, which of the following is the most appropriate drug for preoperative blood pressure control? Preoperative blood pressure control. So here the answer is phenoxybenzamide. The answer is phenoxybenzamide. And this is what which is already explained in our class. I told you, see, alpha blockers, irreversible phenoxybenzamide, it is useful for blood pressure control in preoperative conditions in pheochromocytoma. This is already we discussed in the direct question from our notes. Now, let's see the second one of 55-year-old man undergoing general anesthesia for abdominal surgery shortly after administering of giving non-depolarizing neuromuscular blockers. He developed bronchospasm, hypotension, and flushing. All these things, all this stuff. bronchospasm, hypotension, and flushing, all they are due to histamine release. They are due to histamine. Which of the following skeletal muscle relaxants most likely responsible for this reaction? So here, if you can see in our notes, here I told you atracurium, which is associated with the histamine release. In the box, atracurium, cisatracurium, I told atracurium is associated with the histamine release, but not cis atracurium. So, and there is one more thing here. If you can see, maximum risk of histamine release, I told you the D-tubocurarium will be the first option, followed by succinylcholine, followed by mevacurium and atracurium. So here the answer is atracurium. Here the answer is atracurium. But a few people they're telling like is it muscle the drug which is responsible for histamine release or the drug which is not responsible. Like if the question is like if the drug which is not causing histamine release, cis atracurium don't cause histamine release. If it is causing, then it is atracurium. If it is not causing, then it is cis atracurium. So that's all about this second question. Again, direct question from our notes. Again, it comes to the third one. 24-year-old male undergoing surgery, general anesthesia, sevoflurane succinylcholine is given, and after giving, he developed like increased body temperature, muscle rigidity, and metabolic acidosis, and all the stuff. And here, it's like sevoflurane, inhaled anesthetic agent, succinylcholine. These two are the drugs which are responsible for the development of malignant hyperthermia. So, malignant hyperthermia, drug of choice, we all know that is a dantrolene. Why we will give diazepam, paracetamol, propofol? We don't give all the stuff. Dantrolene, again, it is a direct question from our notes. If you can see it here, malignant hyperthermia, drug of choice is dantrolene. What dantrolene is going to do? It is going to inhibit this calcium release. I told you here, this is a previous year question. I told you this also, the previous, what you call, histamine release, but that is also a previous year question. So all these two are previous year questions, again, repeated. Now let's see one more thing. Benralizumab. Benralizumab mechanism of action. If you can remember our notes from, if you can remember my explanation during this respiratory system, here I told you this benralizumab interleukin 5. If you can remember this part, I told you benralizumab. We are going to block what? We are going to block eosinophils. What we are blocking on eosinophils is a fifth letter. So we are blocking interleukin 5 receptor on eosinophils. That is benralizumab. As I mentioned, we are blocking something on eosinophils. What we are blocking something on eosinophils? We are blocking interleukin 5. So we are blocking interleukin 5 receptor on the eosinophils. So interleukin 5 receptor on eosinophils. That is the correct answer here, right? So I told you this is a very important box here, biologicals. Exact ditto question came from the notes. Next one. So here an asthma patient, she's already using this salbutamol. She's taking this salbutamol and she's also on ipratropium bromide. And now she's developing nocturnal asthma. That is, asthma is not getting controlled. Then what is the appropriate next step? Here, why we'll add montelukast? We don't add montelukast. We don't increase the frequency of salbutamol. We'll be adding corticosteroids. Because in case of persistent asthma, nocturnal asthma, we'll be adding first corticosteroids. If it is not getting resolved, then we'll go for this LABA along with inhaled corticosteroids. So here also, corticosteroids, persistent asthma, or in a maintenance treatment of severe persistent asthma, either oral or inhalational. So that's all about this part, respiratory system. Now come to the next question. The preferred drug in febrile seizure in children. Febrile seizure in children, we all know that is rectal diazepam. It's not normal one, it is rectal diazepam. And again, this is also direct question from the notes here. If you can see febrile seizure in children, I told this is rectal diazepam. Again, I told you this is again a previous year question. Again, this is also a previous year question. So that's all about this, what you call preferred drug in febrile seizures. And if you can see this ethosuximide, it is a drug of choice in absence of seizure. So this ethosuximide, it is drug of choice in absence seizure. Again, that is also a previous year question. So that's all. That's all about this febrile seizure part. Now come to the next one. Again, this is the topic which I told that entire table. I gave in a landscape mode this page number 87. This entire table is important, very important for both INA as well as NEET. This is what I told here. Let's see what they have given. Schizophrenic patient, he's on haloperidol for the past 2 years. This is a take-home point here. That means from the past, there is like long-term history of usage of this drug. So now they present with these involuntary movements of lips, tongue, face, including chewing movements and grimacing. So which gradual worsens, which of the following is here? They didn't ask, like I still remember because I also gave the exam. So they didn't ask about the drug of choice. They asked like what is the feature, what is the diagnosis and what is the treatment? What is the correct matching? That is what they have asked here. So now if you can see, this is not perioral tremors. And then here, if you can see this acute muscular dystonia. Acute muscular dystonia, we don't give ropinol, we give benztropine. And tardive dyskinesia. Tardive dyskinesia, this is what a tardive dyskinesia, because the take-home point here is this part from the past 2 years. From the past 2 years. I think there is some more other things which were given along with this question supporting tardive dyskinesia actually. I forgot the the other features they have mentioned here. Few of the two or three features were there. I forgot what they have mentioned. If you can just reply in the chat box so that I will add to that one and we can upgrade this question also. So tardive akathisia, this is not akathisia, not proper. So tardive dyskinesia, tetrabenazine, this is a correct answer. The main take-home point here is this long-term duration associated with abnormal movements. If they give such kind of question, but if they tell like acutely, maybe within 1 week or 2 weeks or 3 weeks, in that scenario, we can go for acute muscular dystonia, but not ropinirole. Why we will give ropinirole? No, we don't give ropinirole. We give benztropine because ropinirole is a dopamine agonist, which will aggravate. So we give benztropine in that scenario. But here, if you can see, is the old age and then long term. This is what exactly I mentioned here: tardive dyskinesia. If you can see, high risk is old age and it is very late to appear. The differentiating with acute muscular dystonia, this is young individual, which is early to appear. They will give at least weeks, so 1 or 2 weeks, 1, 2, or 3 weeks, they will give in that scenario, go for acute muscular dystonia. That's all. That's all about this, what you call extrapyramidal symptoms question. Now, here comes in antiarrhythmic drugs. If you can remember, I told you if you want to remember something, what you call in antiarrhythmics, definitely you should remember only two things. One is amiodarone, and the second one is PSVT. These are the two things which I told you which are at most important. Read these two things first, and later go to the other part. This is what I told. If you can remember, I told you in the class. And this NEET PG 2025, they gave two questions from CVS, two questions, one from amiodarone, and second one is from PSVT. We see one by one. So this amiodarone. So this is what a image-based question they have asked. Amiodarone mechanism of action. They have asked amiodarone which phase it is going to affect. We all know amiodarone is the one which is a class three, which is a potassium channel blocker, mainly affecting phase three. Along with phase three, it is also going to affect phase one, two, three, two, four also, but predominated by phase three. That is what we know clearly. So here it is going to affect phase three. It is going to affect phase three. This is what I mentioned here. Class three antiarrhythmic drugs. It is going to affect phase three. It is going to affect phase three. That's all. That's all about this amiodarone part. That's all about this amiodarone part. Now come to the next one. So 32-year-old recurrent episodes of PSVT. So now what we have to do, and if you can remember, if you can, what you call, see this question, they asked something about PSVT, but they didn't ask about acute treatment. They asked about prophylaxis. So if you can remember, PSVT, acute treatment drug of choice, we know adenosine. And for prophylaxis, we can use verapamil. Even if you get confused with this part, they have asked a prophylaxis. Prophylaxis is daily, we have to take daily. Why we will take IV? It is practically not possible. So rule out these two. Why will you phenytoin? Definitely we don't give phenytoin. So oral verapamil. This is the correct answer, prophylaxis. So I think November 2024 INI-CET, I think so. They have given the same PSVT question. They have asked acute treatment. The same, almost ditto question. Nothing much difference. So that's all about this CVS part. So this is what you have mentioned here also. PSVT, drug of choice, adenosine I mentioned. But if the patient is having asthma, then we go for verapamil. In case of prophylaxis, we go for verapamil. That's what I mentioned here in the notes also. Now come to the next one. So 60-year-old man with end-stage chronic kidney disease, regular hemodialysis, presenting with a progressive fatigue and pallor. It's like classical case of anemia. Anemia, what you call due to chronic kidney disease. What we will give? We will give erythropoietin analogs, darbepoetin. This is the question. This is the answer. Anemia due to chronic kidney disease. We go for erythropoietin analog. That is what I mentioned here in our notes. Erythropoietin analogs, darbepoetin, which is having a long half-life, anemia in CKD patients. Clearly, it is there in our notes. So that's all about this blood part. And of course, there is one more question in blood. So here, if you can see venous thromboembolism, they mention venous thromboembolism, and like in case of these kind of lengthy questions, I told you, treat from the last line. Which are the following is the drug of choice of venous thromboembolism, prevention of immediate postpartum period? So drug of choice in venous thromboembolism. Obviously, we'll go for low molecular weight heparin. This is what a drug of choice. Aspirin, clopidogrel, warfarin, we don't use all this stuff. Low molecular heparin is a drug of choice for venous thromboembolism. That is what I mentioned here also, prevention of venous thromboembolism. Low molecular weight heparin. This is also a direct question from our notes. So that's all about this blood part. Now come to the next one here. See, in these kind of bit lengthy questions, what I told you, start from the last line. Which are the following drug we are using? And so finally, we got to know here the drug of choice. He is asking the treatment part. Now, just go to the before line. So the physician decide to prescribe a drug that will enhance the gastric emptying and esophageal motility, help to relieve his symptoms. What are his symptoms? He's having GERD. So GERD enhancing the gastric emptying. So obviously we go for metoclopramide. That is a prokinetic agent. Pantoprazole and vonoprazole. This is what a potassium blocker, and this is what a proton pump inhibitor, right? So these are the drugs which are used in peptic ulcer disease. But in GERD we go for metoclopramide because clearly he mentioned in the exam like which will increase the gastric emptying, which will increase the gastric emptying. So this is what I'm told in the entire GIT. Metoclopramide is a question asked multiple times. I told you in the entire GIT, if he wants to ask, generally he won't ask in GIT part because there is a very small chapter. If he wants to ask, he will ask mostly in prokinetic agent. In prokinetic agent, also I told you he will ask mostly about metoclopramide. That too, mostly about the ADR of metoclopramide. ADR of metoclopramide. But now he asked me about the indication. That indication, gastroparesis, increasing the gastric motility. That is also a previous year question, as I told you in the class. So metoclopramide, if you can remember my words in the what you call class, metoclopramide messes with the brain, domperidone don't. Metoclopramide messes with the brain and it is causing the extrapyramidal symptoms. Domperidone will not cause the extrapyramidal symptoms. So that's all about this tetracurium. Yeah, they have mentioned ticks. Yes, 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 yes. Fine. Now let's see what is the primary mechanism of action of pegloticase. Pegloticase reducing the serum uric acid levels. And this is what I want you to answer this question. What you have answered. Definitely, these are not two options, inhibition of xanthine oxidase and the inhibition of URAT. Definitely not these two. I just want students to answer. If you can answer in the chat box, which one you have answered? Is it hydrolysis or is it oxidation? Covered in both biochemistry as well as pharmacology. That one LABA, why not LABA and corticosteroid? Generally, we start with corticosteroid. If it is not getting resolved, then we go for LABA. Anyone? Hydrolysis. Logesh is saying hydrolysis. Still? Mm, People are saying hydrolysis. He didn't mention about allantoin. Oh, he didn't mention about allantoin. That's okay. That's fine. No, that is not hydrolysis. Yes, 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 Kiran. That is oxidation. This is oxidation, not hydrolysis. Not hydrolysis. It is oxidation. Pegloticase, what it is going to do. See, if you can see here, uric acid. This is what direct from our notes again. Uric acid convert to allantoin with the help of uricase in birds. That is through with the help through uricase. What you call we developed two drugs, that is rasburicase and pegloticase, and they convert by oxidation. No, ma, in this scenario, CKD, we prefer what you call this what you call darbepoetin. We don't go for parenteral iron. So this is oxidation. This is oxidation, not hydrolysis. This is clearly in our notes also it is mentioned. This is oxidation. So that's all. So it is given as inhalational corticosteroids plus lava. Other option is only oral steroids. Go for the inhalation corticosteroids, sir. Go for inhalation corticosteroids. Because I'm not sure about the option. That's why I'm a bit doubt in that question. In these kind of like few discrepancies, please let us know. So that is oxidation. It is not hydrolysis. This is oxidation. See, it is there in our notes, page number 171. This is oxidation. It is mentioned. It is mentioned. So that's all. That's all about this gout part. I told you in NEET, autopoids is a very favorite topic, either gout or rheumatoid arthritis or migraine. I told you these are the three topics which he mostly concentrate on. Now he concentrate on two topics. What you call both uh, rheumatoid arthritis, sorry, gout and as well as this migraine. Now let's see. Now let's see here. This is a migraine, and he asked like most appropriate choice for the profile axis of the migraine. And here you might have confused with this coronary artery disease and everything, right? So here they have given she started with sumatriptan and she had this triptan sensations like developed chest tightness and all this such stuff. And later she wants to use this good drug for prophylaxis. Always, I told here the most common one, most potent one, that is beta blockers, because here she don't have any history of coronary artery disease. If there is any contraindication to these non-selective beta blockers, then we go for, if there is any, then we go for this topiramate. Then we go for this topiramate. Parental iron should be given before darbepoetin. No, man, no, no. We can go for what you call darbepoetin, ma. You need not to give parental iron, and we need to wait. We need to check the iron stores and everything. Not required. We can go for darbepoetin. Because erythropoietin production itself is decreased. No, because in chronic kidney disease. That's what clearly mentioned. Yeah. We go for phenoxybenzamine. We go for phenoxybenzamine because the question itself is like, yeah, I have read that question, Akash. Like pre-operative, definitely we'll go for phenoxybenzamine. If you would have given only intraoperative, then intraoperative, post-op, then we'll not go for phenoxybenzamine. If here they have mentioned this, what you call pre-operative part, go for phenoxybenzamine. Later, during intraoperative procedure, we still go for these beta blockers and other stuff also. So that's all. This is propranolol. This is the most effective drug. Most effective drug, propranolol. No personal history of coronary artery disease. No personal history, right? We go for propranolol. Next one. Next one, and these are the like in chemotherapy, he has asked about I think three or four questions. Three questions are from HIV and TB. This, if you can see, 36-year-old man present with fever, weight loss, cough, and diagnosed with pulmonary tuberculosis. Yes, 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 we can give, we can give. There are like we have told the classical contraindications of non-selective beta blockers, those asthma, bradycardia, heart blocks, all the stuff. Those things are not mentioned here. Those things are not mentioned here. So we can go for propranolol. So his HIV test is positive, but he's not on ART or anti-tube ART and ATT. So now, what is the next step in the management? What is the next step in the management? So here, if you can remember, here I told you in HIV chapter, like immune reconstitution, inflammatory syndrome, that is IRIS. In that scenario, in case of this HIV and a TB, we go for first, we start with the TB drugs, and later we'll wait for 2 to 8 weeks, depending upon the CD4 count. Later, we go for ART. Later, we go for ART. So, this is what I told you HIV, iris. So, here, first, we start with ATT. We don't start ART immediately because risk of what you call immune reconstitution, inflammatory syndrome. We don't start simultaneously as well. Start ATT first, later initiate ART within 2 to 8 weeks, depending upon the CD4 count. We given nitroprusside and esmolol intraoperative. Yeah, that nitroprusside and esmolol is not given in the option, right? It is not there. Or the options were phenoxybenzamine, clonidine, esmolol, and nifedipine. These are the only four options they have given. They didn't give this what you call combined option, right? So based on the given options, we go for the phenoxybenzamine based on the given options. If you can read that instructions before starting the exam, the first instruction was the question will be there, and we have four options. In those four options, the most appropriate, the correct answer or most appropriate answer or relevant answer. That is what the first line they have mentioned in the before starting the exam. If we can remember that. So based on the given options, we go for phenoxybenzamide. Hope you understood, ma. Let's do it. Hope you understood. So that's all about this, what you call iris. First start ATT, later go for ART. 2 to 8 weeks gap, depending upon the CD4 count. So clearly they have given. And I don't know what is this fourth option. If you can remember, uh, please let me know that fourth option, iris. So that's all. That's all about what you call this part. And then coming to this one again. So 38-year-old man newly diagnosed with HIV, presents with pulmonary tuberculosis, and it says rifampicin resistance in this question. The person is having rifampicin resistance, and later we start some treatment, some bedaquiline, all the multi-drug resistant treatment will start, and then which of the following, like the question was, which of the following drugs we can give and what complication we need to monitor. That is what I think so. So drugs, we can go for this bedaquiline drugs, and complication it is like this iris part. And this is what my first option. Uh, this and remaining all are like peripheral neuropathy and hepatotoxicity, all those things were there. And the option which contain this iris, you need to monitor that. The drugs, obviously, the bedaquiline, levofloxacin, linezolid, all the things. This one you need to monitor. Hope you understood now. So this iris part. So two questions they have given HIV with a TB. Two questions. And this is what I already mentioned again, the same thing. Again, the same thing. Because of iris, we need to start ATT. Next one. A 19-year-old college student has been close contact with a roommate recently diagnosed with meningococcal meningitis and asymptomatic, and for chemo prophylaxis, which of the following is a drug of choice? Rifampicin. Rifampicin is a drug of choice. If you can see this entire TB box, all the indications I told you, each almost every point is given as a question. Here, if you can see this meningococcal meningitis prophylaxis, meningococcal meningitis prophylaxis. Yes. Isoniazid, levofloxacin, ethambutol, and pyrazinamide. I'm not sure about those options actually, but you need to take care of the iris part. You need to take care of that iris part. That I can tell. Yes, which drug can be given both pre-operative, intraoperative? Definitely not a smaller. That was a question asked, which can be given both pre-operative, intraoperatively, or which is the most preferred drug. Okay, we'll finish this part and we'll come back to all the queries. Okay. So next one here, HIV vertical transmission. Vertical transmission, if you can see, I told you in our notes here, in this vertical transmission, low risk, depending upon the low risk status and a high risk status. Low risk status, if they're less than 1,000 copies. But if you can remember, in this question, they have given, I still remember they have given like 1,200 copies. It is more than 1,000 copies. So it is a high risk status. So we give two syrup, nevirapine and zidovudine. So syrup, nevirapine and zidovudine. Both we will give. Both we will give. Not doxy, ma, not doxy. Sanjit, rifampicin, rifampicin. It's rifampicin, rifampicin. Doxycycline doesn't have much effect. Rifampicin. Rifampicin is the one which is for prophylaxis of meningococcal meningitis. That is already mentioned. Where okay. The other options were amoxicillin, okay, is saying ciprofloxacin, ciprofloxacin, chloramphenicol. Rifampicin is the drug of choice. Prophylaxis. So that's all. This again, high risk status, nevirapine with some zidovudine. Nevirapine with both we will give for 12 weeks. That's all. And then come to this part on this diabetes. I told you in endocrine, diabetes, the most important one. In the diabetes, this SGLT2 inhibitors are again the utmost important one. Almost every year they'll ask about these SGLT inhibitors in the exam. Either it is INI, two INIs, and one NEET. Out of three exams, definitely I can tell maybe two or three exams they will ask about these SGLT2 inhibitors. So here type 2 diabetes mellitus, and if you can remember HbA1c, they have given like a 8.1. The patient is on insulin and metformin, and the ejection fraction is 35. Then which of the following drug we can use? Which of the following drug we can use? As you know, gliflozins, SGLT2 inhibitor, these are the drugs which we use indicated in heart failure. This is what indicated in heart failure, gliflozin. Clearly, I mentioned contraindicated in heart failure, pioglitazone, rosiglitazone, pioglitazone and rosiglitazone. So one question which a drug, that's what like I'm not sure about that question actually. That belongs to derma, I think so. Like they'll cover in the derma part. Like options, I remember like a beta blocker, some fluconazole. I don't know whether it causes that plaque discolorization or like treatment. I'm not sure about that exact. What is the question there? Beta blockers, fluconazole, and lithium. They have given. It's like lichen planus. Is that so? And after eating spicy food, some burning sensation. That is what the question they have given, right? We'll cross-check that front. We'll let you know, ma. Yeah, rifampicin. Rifampicin is the answer. Even though they have given doxycycline, rifampicin is the answer. So that's all about these drugs indicated in heart failure. Rifampicin. Go for rifampicin, Harika. So now here, and can anyone tell me what is the exact question here? Like hydrochlorothiazide, is it contributing to renal stone, or like what is the effect of thiazide diuretics in calcium? I'm not sure about this exact question. If you can let me know, we'll sort it out here, or otherwise I have a homework to find it out. What is the exact question? If the question is like thiazide diuretics, what it is doing with the calcium, it is going to increase the reabsorption of the calcium or like decrease in the calcium excretion. Nandini Mohan, okay, increases citrate. Yes, 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 yes. Auxiliary reabsorption causing renal stones, increased auxiliary was an option. Okay, increased citrate. Yes, 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 yes. Increase citrate. Then this will be the option. Renal stones cause increases citrate. Thiazide causing generally thiazide, they are used in the treatment of what they call nephrolithiasis, increased citrate absorption. Yes, 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 yes. Decrease or oxalate. Is that so? Increase citrate. Answer will be increased citrate. No, they don't increase the calcium excretion. Increase citrate. Increase citrate. Increase citrate will be the one. And Thyroid diuretics decreases the calcium excretion. Don't get confused here. Thyroid diuretics decrease the calcium excretion. This is what I'm not sure about the question exactly. So these are the questions. These are the questions. Yeah. I'm not sure about the exact question, but we know like if thiazide diuretics, they don't increase the calcium. That is what we have discussed. So these I'm not sure what is like exact thing. If people are telling there is increased citrate and decreased oxalate, that's fine. So that's all. Any other questions from pharma that I make a note? Decreased calcium excretion is also there in the option. Okay, that's fine. So that oral ulcer question. Okay, that's fine. I'll check it out. Any other questions apart from these? One option was decrease citrate. Okay, fine. I'll make a note of it. Anonymous, I'll make a note of it. We'll rectify that. We'll try to identify the exact question and we'll let you know. So any other thing other than that oral ulcer, that image-based one? Yes, 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 yes. What is the reason? Yes, yes, Akash, I understood. We'll get back to you. Any other questions other than the discussed ones? Any other question which left except that image basis some ulcer, some discolorization in the oral cavity? Apart from that image, is there any other thing left? So how was the pharma paper? So yeah, is everything okay with pharma? Farm person resistance in TB, HIV. We go for that bedaquiline, ma. Bedaquiline, predominant lichen planus. Yeah, yeah, yeah. That's what like around like lichen planus one. We'll get back to you with this exact question in derma. The options were like beta blockers and fluconazole, lithium, and the ciprofloxacin. These are the four options. We'll get back to you. So that's all. That's all about this entire what you call. Yes, 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 yes. Ciprofloxacin, not azithromycin. No, no, not azithromycin. These are the four options they have given. Target answers. Okay, expression, okay. I didn't get you, Pavitra. If any other questions, if I maybe if I would have if any questions left by chance, you can just text me to my Instagram account, Sudhir Prudvi, or if any errors in the questions or in the options, those are written in the last answer. Okay, thank you, Pavitra. Thank you, Pavitra. You can just text me in Insta if any questions left or any changes in the options or in the questions. I'll correct them. I will edit and I'll correct them. Because in that asthma question, it was oral corticosteroids in one option, LABA with we go for this LABA inhalation, Then if it is like oral, then we go for this LABA inhalation part. I thought that was like a inhalation corticosteroid. If it is oral, then we go for this LABA inhalation only. This was the image. I didn't get image, Nabil. So done. If any questions left or any slight discrepancies in options or in the questions, please let me know. Text me. I'll update them. So that's all then. That's all about this pharma. So, so total, I can tell you there are like almost 21 or like 20, 21 roughly. 20, 21 questions. Almost everything is from the workbook, the picture, almost everything. As well, I didn't take this vertical question bank because I don't have time. I immediately came to live. So almost everything, direct questions from workbook. So that's all then. We'll wind the session now. If anything is there, just text me. If any other discrepancies or options are in the questions, anything, just text me. Where to send image? Okay, just send that image to my Insta, Nabi. This is what my Insta ID. Just send that to me. We'll add that one. That's okay. Okay then. We'll wind up the session. Thank you all.